Everyone, we'll just wait a couple of minutes before we start the webinar. Thank you for joining us. So we'll wait another minute or so just to enable people to join, and then we'll get going. All right, we might get started if that's okay. Thank you everyone for joining us, and welcome to the Australian Institute of Health Innovation webinar series. And today we're talking about innovation in the management of patients with heart conditions. And you're in for a treat. You're going to hear from some people from Macquarie University as well as from the University of Tasmania. We're going to be talking about two different models of care in cardiology. So the Australian Institute of Health Innovation is based at Macquarie University. And we're a large research institute. Although we are based at Macquarie, we do have a national and indeed an international footprint. We do lots of large collaborative projects. The types of projects we do have nothing to do with sort of clinical research necessarily, nor do we splice genes or do we do any sort of DNA research or bench research. We actually answer quite thorny questions about the health system and health services. We try to improve the efficiency and effectiveness of health services and systems. So my name is Yvonne Zurynski. I'm the Associate Professor of Health System Sustainability at AIHI at Macquarie University. I lead a large partnership centre grant, NHMRC Partnership Centre grant in system sustainability. And I have a special interest in integrated care, both for children and adults. So this webinar is of particular interest to me as well. Welcome everyone. And just before we get started, I would like to do an acknowledgement of country. So we acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumattagal people of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. We acknowledge the traditional custodians of the various lands on which you all join today, and the Aboriginal and Torres Strait Islander people participating in this webinar. We pay our respects to elders past, present, and emerging. So welcome everyone. This webinar is being recorded and it will be available on the AIHI YouTube channel for viewing later. Questions, if we could keep questions to the end, but you can add your question as you think of it into the Q&A on your Zoom platform. So please do that, because often people forget. They think of a good question and then by the end it's forgotten. So please try and do that. At the end, we're going to have discussion, and we really would appreciate having some interaction with all of you online. All right, so I would like to introduce our fantastic speakers. So in addition to myself, we have Associate Professor Krishan Nalaya, who is an academic cardiologist with an interest in prevention and cardiac arrhythmias. Dr. Nalaya is a National Heart Foundation postdoctoral research fellow and is clinical lead for the HeartConnect project, which we'll be talking about today. We also have Dr. Neve Chapman, is a postdoctoral research fellow at the Menzies Institute for Medical Research and deputy chair of the International Society of Hypertension, Women in Hypertension Research Committee and Emerging Leaders Committee of the Australian Cardiovascular Alliance. And Neve and I have worked on a couple of projects together as well. And Andrew Black, Dr. Andrew Black is a staff specialist at the Royal Hobart Hospital and visiting specialist at Hobart Private. Dr. Black has a particular interest in improving systems of care for Tasmanian cardiac patients and is the clinical lead for the Tasmanian STEMI network and Tasmanian principal investigator for the Victorian and Australian cardiac outcomes registries. So please welcome our speakers. I think we have a really great program ahead of us. And we're really talking about integration and taking a comprehensive and integrated approach to caring for people with common, rare and complex heart conditions, delivered with better support for patients and their families as well as clinicians. So I've already said in this webinar, you're going to be hearing from researchers and clinicians from Macquarie Uni and from University of Tasmania. And we're really talking about providing rapid access to specialist cardiology, whether through a rapid access chest pain clinic in a hospital that Andrew and Neve will be talking about, or a rapid referral service such as HeartConnect outside of the public hospital system that Krishan runs and I was involved in evaluating. So I might hand over to the first speaker, which I believe is Andrew. Perfect.
I'm just getting us into presenter mode. So we're going to present together as a amazing duo.
Fabulous. Thank you very much.
And there we go. So you should be able to see the right slides now. Yep. Great. So thanks, Yvonne, for the introduction. I would just like to thank you for the wonderful acknowledgement of country and also pay our respects to the Polo and Pakana people of Nutrita and of Tasmania, the lands in which we're dialing in from today. So as you can see, Andrew and I are dialing in together from Tassie, and Andrew's a cardiologist and I'm a health services researcher, which I think gives us a really good perspective to provide some input into the Tassie experience. But I would like to say that Andrew's going to be telling us about work that he's been leading for several years. And then I've come in kind of with a lot of enthusiasm towards the end. So I'll be talking towards the end of our slides, but just a brief overview to set the scene. I'm sure many of you are already aware of this, but I've quite enjoyed preparing for this presentation because I've just been writing one of those MRFF EMCR grants. So it's nice to take a few steps back and make some pretty slides. And I think this really addresses two urgent health priorities. The first one being the overstretched and overburdened emergency departments across the country, but also that cardiovascular disease remains the leading cause of death and disability across the country and across the world. And we could really do a lot better with prevention. And I think by targeting our systems rather than trying to change individual behavior at the patient or the doctor level, we can address these two urgent health priorities with models of care like the rapid access chest pain clinic that Andrew's going to talk about. And I was quite startled to think about playing around with the numbers to highlight the burden that we have with the problem of chest pain. And that's actually equates to one person every single minute across Australia presenting to an emergency department with a chest pain presentation. And that's pretty startling when you think about it, because 85% of those patients don't actually have an immediate risk of acute coronary syndrome. So I'm going to hand over to Andrew to talk us through what is usual care and how has he innovated in Tasmania.
Okay, thanks, Neve. So we've got all these people presenting to emergency departments with chest pain. So anyone with chest pain, generally the emergency department's the place to go to be seen at first. Now, acute coronary syndrome or essentially heart attack can be excluded using a combination of an ECG and a blood test called a high sensitivity troponin. And if those two tests are normal, it does put the patient at low risk of adverse events out to about 30 days, and it excludes an immediate sort of cardiac emergency. But they still need ongoing follow-up and further investigation because a small number of those patients will still have an underlying important cardiac condition. Now, these investigations are generally organised either as an inpatient or an outpatient. And what happens in sort of usual care is the patients will tend to bounce around the health system from the emergency department to general practice, to general medical clinics, cardiology clinics, and various investigations in between. And that follow-up can span over many months and sometimes even, when we looked back at our old system, up to years after a single episode of chest pain. And in between times, the patient can have several representations to the emergency department because there's uncertainty about their follow-up. So rapid access chest pain clinics were developed in the United Kingdom many years ago and were spread out for widespread use through the UK. They're also used in a number of other countries. But there's not the actual evidence basis for using this model of care was certainly lacking when they were implemented. So what we've aimed to do is to implement this service here and then have ongoing research and review to see whether these are actually fulfilling the purpose they were designed to do. So essentially the way these clinics work, a patient's referred by the emergency department or by general practice. So if someone's got chest pain that's resolved a couple of days ago and they see the GP, they might be appropriate to come to see us rather than the emergency department. We specifically don't see patients with a previous cardiac history or patients with multiple different issues. So patients with, for example, new murmurs, blackouts, that sort of thing, really because we try to see these patients once and then follow them up only if necessary. So patients that have a cardiac history or have multiple different system issues are better seen through a general cardiology service or a general clinic because they're more likely to need ongoing review. We recognise the fact that the patients that are referred to chest pain clinics often have a high burden of modifiable risk factors. And so the patients are all seen by a nurse prior to being seen by the doctor so that they can have a careful evaluation of their risk factors and then calculation of absolute risk scores. So we're addressing two problems really. One is the chest pain that brings them in, and the other is the underlying risk factors, which is often part of the reason that they're referred. So patients that have more risk factors are more likely to be referred to a service like a chest pain clinic. So that's the specialist review. And then they undergo further investigation if indicated. The reality is most patients that come through a chest pain clinic will require some kind of additional testing like an exercise test or a cardiac CT. And then the patients are followed up by the GP. So the results are conveyed back to the GP, and if they're significantly abnormal, which they are only in a minority of patients, then we'll contact the patients directly and organise appropriate follow-up. So again, the system works because we see the patient once, we're not having them coming back for multiple review encounters. So there's the potential for rapid access chest pain clinics to streamline this process, save money, improve patient care and outcomes, and benefit service providers like the emergency department and GPs because there's more certainty about how patients are going to be followed up. So prior to 2014, chest pain outpatients through the Royal Hobart were seen in a mix of the general cardiology and general medicine outpatient clinics. We ran a rapid access chest pain clinic pilot project in 2014 to 2016. And then after the success of that project, it was adopted as usual care in 2017. At that point, we also embedded a clinical trial that was looking at specifically at the evaluation of risk factors within that clinic and then trying to put in place strategies to modify risk factors for future events for patients. In 2020, we switched the clinic to telehealth because of the start of the COVID pandemic, which obviously is dragging on. And that gave us a chance to evaluate a telehealth model of RACPAC, which we'll run through briefly. And we've now switched back to an in-person RACPAC, although that may change in the next few days again. In 2019, we published a study evaluating the comparison of a rapid access chest pain clinic versus a general clinic. So this was a prospective evaluation of our new rapid access chest pain clinic versus a retrospective control cohort of patients with chest pain that were seen in the pre-existing general clinic, so a sort of usual care group. So these are patients that would have been eligible for RACPAC if it was around. So this was 1479 RACPAC patients versus a control group of 435. They were mostly, as you would imagine, middle-aged patients. There was a high prevalence of modifiable risk factors. So lots of patients had high blood pressure, diabetes, and high cholesterol. This was patient reported. So there were also patients who had new diagnosis of significantly elevated cholesterol that weren't previously aware of that. About a quarter at least were smokers, and about a third had calculated moderate to high 5-year absolute risk scores. So again, the absolute risk scores reflecting a high burden of risk factors that is not immediately relevant to their initial assessment with chest pain, but it does put them at risk of subsequent events over the next 5 to 10 years. When we compared the referral volume, so the actual referral volume between the Rapid Access Clinic and our previous usual care clinic was similar. So these are the same patients, we're seeing them anyway, we're just seeing them much more quickly and much more efficiently. So we're not creating an additional workload, we're just doing things smarter, I guess. What's interesting is that most of the patients referred to RACPAC came from the emergency department, whereas most coming to the general clinic before came from GPs. And this reflects the previous practice where patients would be discharged from the emergency department to follow up with their GPs. And then the GPs were routinely re-referring most of those patients back to the public clinics. So again, you're looking at potentially a 2 to 4 week delay in care just through the referral process. Most of the patients had normal ECGs and troponins, as you would expect for an outpatient service. So if you look at the service outcomes, the time to review was significantly reduced down to 12 days from a median of 45 days and sometimes much longer through the general clinic service. Our target time to review was 2 weeks, so there's a few patients come in over the 2-week target, but that often reflects the patient preference for particular appointment times, and that's been reported by other services. We've potentially prevented 1,200 follow-up visits if we compare the number of follow-up visits in the general cardiology service. So a lot of these patients were having 2, 3, 4, 5 follow-ups before a conclusion of service was made. The investigation rate was similar. So again, most of these patients do have an investigation, and that rate at 80% was a bit higher through RACPAC than the general clinic, but that probably again reflects the fact that we're seeing people more quickly. If you're seeing someone 6 months after an index episode of chest pain with no recurrence, you're probably less likely to investigate them. The important difference here, though, is that the rate of invasive investigations or coronary angiography, which is the most expensive and carries some risk investigation, was significantly lower in RACPAC than in a general cardiology clinic. And that presumably reflects streamlined access to alternative testing. The 12-month emergency department representation rate, this is the really important one, was substantially reduced with RACPAC compared to the general clinic, again, because we're seeing people quickly and sorting them out quickly as well. In terms of clinical outcomes, about 10% of patients coming through RACPAC had a cardiac diagnosis relevant to their presentation. About half of those required revascularization, so had a significantly narrowed artery, coronary artery that needed to be fixed with a stent or surgery. And then the other half had a variety of other diagnoses like cardiomyopathy or arrhythmia or valvular heart disease. So the cardiac diagnosis rate was higher than in the general clinic. And again, that probably reflects a streamlined access to various investigations that gives us a look not only for obstructive coronary disease, but also allows us to consider alternative diagnoses. And the MACE rate was low. So MACE, for people that aren't familiar, is major adverse cardiovascular events. So things like heart attack, stroke, and unplanned revascularization, and cardiac death. So much lower in the RACPAC group than the general clinic group. A couple of just minor issues to note is that there were about 20% of patients who didn't have any investigation from RACPAC, and none of those patients had adverse events at 12 months. So there is a group of patients who can safely be not investigated. Whether it's possible to maybe increase this percentage is something that we'll need to investigate over time. And in the time from the referral being made to review in RACPAC, there were no adverse events. So this waiting time of about 2 weeks seems to be quite safe, which is reassuring because in the UK, the recommendation is to be reviewed within 72 hours. So the 2-week time period is more practical. So in terms of feasibility, the clinic model appears to be safe and efficient, reduces a burden on the emergency department in particular, but also on general practice, which is really struggling now, particularly at the moment. And then there's the potential to value add by modifying risk factors to try and prevent those events down the track. So one of the questions that was outstanding from our initial experience is, do we then get a sustained benefit from this opportunistic absolute risk counselling that comes from the clinic? And so that led to the development of the ARCPAC clinical trial. So here we randomised 220 patients to usual care versus an absolute risk-guided proactive risk management approach, where basically we worked out what the patient's absolute risk of events over the next 5 years was based on their modifiable risk factors, and then put in place proactive strategies to try and manage those with the patient. And importantly, it involved a discussion with the patient about their absolute risk score. So for people that aren't familiar with risk scores, this is how they're derived. This is the Australian risk calculator. You basically plug in basic details about the patient and it gives you an idea of their 5-year risk. This is quite an engaging thing to do with patients. We know that they systematically underestimate risk, and it's a good way of describing to them what their risk is and also what the risk can become with relatively simple changes to their risk factor profiles. And what we found is that if we look at the top histogram there, this is the usual care group, and the change in absolute risk score clusters around 0, meaning there was generally not much change or a slight increase. The reason for the slight increase is that patients get 37 months older, and that drives their risk up. Whereas in the intervention arm, there was a substantial reduction in their absolute risk scores, driven by an improvement in all of their modifiable risk factors. So even this relatively brief intervention does have ongoing benefits. And then just briefly, our experience during the COVID period with telehealth. So we know that health systems were significantly disrupted and continue to be disrupted by COVID. RACPAC was determined locally to be an essential outpatient service. It reduces emergency department presentations, which is exactly what we want to do during a pandemic. And so we switched the service to telehealth to try and facilitate ongoing RACPAC review. And at the same time, there was a desire to try and reduce that testing burden to avoid patients coming into the healthcare environment if they didn't need to. We put in place an additional safety net phone call at 30 days because it was hard to be sure if this reduction in testing was completely safe, as it hadn't been investigated previously. So what we found is that at clinician discretion, we reduced testing by about half. There was no difference in the cardiac diagnosis rate. So that's reassuring that we're still picking up all the cardiac pathology. That rate sits at about 10% and has been very consistent all the way through. Patient satisfaction was high, and there were no additional adverse events compared to the previously published in-person clinic. A couple of brief considerations for people in the audience that are thinking about setting up a rapid access chest pain clinic. One is to avoid a rapid access cardiology clinic. We're about to hear about those in a minute, and there's nothing wrong with those clinics, obviously. But the reason a rapid access chest pain clinic works for chest pain is that we see the patient once, and if you start putting multiple issues into that presentation, you then have lots of review appointments, which makes it harder to see new patients and potentially collapses the service. Consider investigation pathways. So we see the patient first and then we order an investigation depending on the presentation. An alternative model is to stress test everyone before they're seen in the clinic. But one of the drawbacks with that is that you tend to end up with a fairly high rate of second tests if the exercise test isn't the right test for that person. There needs to be a safety net, obviously, for checking results. There's a large number of tests ordered, and there's all sorts of bits and pieces like lung nodules picked up on CTs, and it's useful to have a double checking process for making sure nothing's missed. The difficulties meeting review targets I've mentioned, so patients will often not necessarily come into the first appointment. They'll pick a convenient appointment, sometimes 3 months down the track, which can be problematic. And then the follow-up options. So we've pushed a lot of the follow-up back to GPs with good communication back from RACPAC about the results of the test. So again, obviously, if something's significantly abnormal, we'll recall them back to the appropriate clinic. But for most of the results, they can be followed up in the community, and it's quite a good opportunity to encourage patients to re-engage or engage with general practice. And which staff? So I'm a cardiologist, but we also have cardiology registrars, general physicians, and general medicine registrars running the clinic. And Perth, the Royal Perth over in WA has reported a really good experience with nurse-led rapid access clinics as well. So there's lots of different models to consider. And I'll pass back to Niamh.
Cool, thank you, Andrew. So much like you have just listened to Andrew present that very compelling data, I was in a similar position probably a year or more ago, or several years ago now, when I heard Andrew talk about this clinic and was really wowed, to be honest. So that's a reminder, based on what Andrew's presented so far, feel free to pop your questions in the chat and we'll attend to those later, or any comments with thoughts that are bubbling up so that we can have a lively discussion at the end. But I've come into this kind of at the end with more of that implementation researcher viewpoint, being like, that's really cool. How can we now take what Andrew's done in Hobart, scale that up across Tasmania or even nationwide? Can we optimize delivery further? So I suppose I came into this a bit naive, looking at it with how do we optimize delivery in terms of the number of investigations that are required? What's the patient's viewpoint in terms of what would add value to this service? Do we need to look at business case funding models, sustainability? What does discharge look like, and how do the receiving physicians feel about that, but also how do patients feel about that? I'm sure that there are some cracks that people fall through, but also how do we address this in different resource settings? So in rural, regional, remote communities, but also communities that maybe have a more diverse population than what we see in Tasmania. So we're very fortunate to receive a grant this year from the Royal Hobart Hospital Research Foundation to undertake a process evaluation. So essentially using that nice quantitative data that Andrew presented today to look at then, okay, if I try and unpack this further and start looking at pockets of patient characteristics or patient journeys and pathways, what can that tell me about the way this service is delivered? And then I'll follow that up by doing some observations and interviews, and that will be of the patient journey, but also of specific staff. So of Andrew, of the general medicine experience, of the registrar experience, and of the nurses. And what we're really trying to understand there is, one, what contextual factors result in the success of this service? You know, do you need an Andrew everywhere to do this? That wouldn't be super sustainable. And two, how could we implement this in somewhere where the context is substantially different? And then also thinking about what's the mechanism that makes this work, and how do we keep stripping that back so that it becomes more sustainable? So we could have the Rolls-Royce version or the Honda Civic version. Both are really important depending on where you're doing it. And then thinking about the outcome. So I think Andrew really nicely described that the outcome is seeing patients timely about their chest pain and them not having a cardiac event, or that's missed, or picking up a cardiac diagnosis where that needs to happen. But then also an additional benefit potential outcome is future cardiovascular events and embedding that absolute risk model. And I think having that value add mindset is so important when we're trying to use scarce resources. So that's the lens that we've come together with trying to think about this, and essentially thinking about that started in a Tasmania focus, which I'm just going to very briefly show this slide, which is my interpretation of the main steps of a process evaluation, which is you kind of get a gist of what's happening based on your quantitative process data, and you go, I think this is happening. And then we go, okay, let's gather some qualitative data with observations and interviews and see if that makes sense. But it's likely that's also going to show us some things we hadn't thought about before. And then I typically bring all that data back together and I discuss that with some of the clinical team, because they're going to be able to help me make sense of it. And then we decide, okay, do we need more information? Do we go back and retest, or do we start to wrap up? And when Andrew and I were working through this, I think it really highlighted for me that the outcomes we wanted to achieve were a local quality improvement plan. So again, optimizing that service. But then I was really thinking, how can we implement this in the northwest coast of Tasmania, where we know the burden of cardiovascular disease is so high, but how do we also continue to evaluate new services? And that's kind of what's led me to the MRFF I was writing this week, where the more I delved into it, the more I realized we're actually doing similar things across the country, but we don't have rigorous evaluation across the board, and we don't have an implementation framework that helps us cross compare those models of delivery, which is kind of where we're up to now. And I think the overall goal is making better care usual care, which I've coined as the goal of this project. But something that Andrew said that I want to reiterate is really looking at that patient and thinking right patient, right test, right time, and how do we embed that in a system to support individual decision making. And with that, I'll stop sharing screen.
Okay, thank you so much, Andrew and Neve, for that presentation. I hope you can hear me. For some reason, I can't start my video. Chrissy may need to do it at her end. Thank you. We might now go to Krishan, who's going to talk about the model of care HeartConnect at MQ Health, which links specialist cardiologists with general practitioners. Over to you, Krishan.
Thank you very much for the opportunity to speak here today and to share our experience at Macquarie University Hospital and Macquarie University. Look, we really have commenced essentially a rapid access cardiology clinic as part of our broader HeartConnect program, which is a program aimed to engage with local practitioners with the view to improving cardiovascular care in our area. And the rapid access cardiology clinic is really one aspect of it. It's very different, I guess, in a lot of senses to what you've heard. The main engagement here is with general practitioners rather than with an emergency department. So the aims were really to work as part of a team with primary care physicians to firstly identify gaps in our current models of cardiovascular care in our region. Secondly, to improve cardiovascular outcomes by addressing those gaps. And finally, to improve access to quality cardiovascular care. And I think the term team is really quite critical to the way that we approach development of this model and its implementation, because it really did require a multifaceted view in order to roll it out. Our team included institutional cardiologists and general practitioners to initiate the program, and also the community general practitioners to really get a sense of what was needed. The AIHI, which facilitated ongoing evaluation of our program, which Yvonne will speak to later, and our local health network, primary care health network, who also facilitated communication with the general practitioner community around us. So I guess in considering our program, it's really important to understand where Macquarie University Hospital is placed within the broader landscape of healthcare nationally and locally. It's important to know that we are a private teaching hospital, and as such, at present, we do not have a emergency department. So the vast majority of our referrals to our hospital come from general practitioners, other specialists, but basically on an outpatient basis. We do also get, a substantial proportion as inter-hospital transfers. So in focusing on our program, what we are unable to provide is really acute care. So this is not a program that's focused at capturing patients who require urgent revascularization with a stent or bypass. It's really a program that's aimed at outpatient care and delivering that in an expedient way. But what we do have is that we have a very high quality and broad array of subspecialty services within cardiology and across multiple specialties. And we really do strive to have sort of the highest levels of technology and procedural expertise when it comes to delivering cardiovascular care. So we have those things to offer. So, we often, in terms of, to put this within a clinical context, we often focus on people such as with stable chest pain, palpitations, where there is a sense of urgency both by the GP and the patient to have these things evaluated, but it certainly doesn't fall within the acute context. So we identified that, that the current treatment for our area, or the current gaps in treatment in our area through consumer engagement, and that really came in two main forms. The first is discussing and disseminating our idea with the general practitioners to get some feedback as to what is important to them, and also to get some feedback from patients in our region. In talking about this, it's important for us to understand that, we're sort of in the north of Sydney. We have a population that is, relatively, their age they're relatively young, although not young, and we're on a university campus, so we're surrounded by quite a young population immediately. And you know, a lot of people in this region are also in the workforce, and so those limitations place or those characteristics place different drivers on what's important to patients in our region. So there were 4 central gaps identified in talking to these consumers. Firstly, you know, GPs felt that it was really important that they be able to access cardiology advice very quickly and efficiently when required. So that is when a patient is in front of them and they have a clinical question or a query that they need addressed, it was quite important to them to be able to access cardiac advice. And while they're able to get this through traditional streams and traditional relationships that they may have with general cardiologists, it was not always immediately available. The second was, of course, rapid, high-quality patient review. You know, waiting lists for patients to be seen can often stretch out to weeks. And, you know, the patient that is anxious or the GP that is anxious to have the patient seen, if they cannot be seen within, you know, a couple of days, then the other option is to send the patient to emergency, placing extra burden there. And one of the really interesting aspects of consumer engagement was our third point here. One of the main issues that GPs spoke about, one of the main limitations, was an absence of rapid feedback to them. Patients would often come and see them with a complaint. They would then go off to a specialist. They would be evaluated, but because correspondence and communication back to the GP was often sluggish or slowed, the patient would often represent to the GP for updated management and treatment, but the results and conclusions from that initial assessment were not freely available. And consequently, the GP was kind of stymied. They didn't really have the data at hand to be able to progress the patient's treatment. And this was a real frustration to GPs that they were quite vocal about. And finally, because of a very mobile workforce in our region, it was very important to patients and GPs that investigations be performed as expediently as possible. In the context of a private cardiologist, it can often be very difficult to schedule appointments and the necessary testing, even if basic, such as an echocardiogram or a stress test on the same day. Often a patient will have to represent multiple times in order to have a comprehensive assessment to stratify their risk and to put their anxieties at bay. So this was another area that we thought would be important for us to focus on to distinguish our service and to provide the rapidity of access and management that was sought after. So in order to address the first issue, we created a rapid access hotline. Now, this is really a telephone service that's available to GPs during business hours, and it's generally manned by one of our nominated cardiologists at Macquarie University Hospital. So there are a number of cardiologists that are interested in this program and have signed up to be part of an on-call roster. You know, perhaps once a week or once a fortnight, they'd be expected to have any phone calls that surrounding GPs may have regarding advice on patients in front of them directed to them. And we utilized a central phone line or a central phone number that was advertised broadly. If there is ever a clinical query, then the GP can ring that single phone number or phone line, and then that phone call will be diverted to the on-call cardiologist automatically. This has worked reasonably well so far. And it provides that immediate feedback that GPs have specified that is important for their care of patients. And then in order to develop a cardiology service that's able to accommodate patients promptly, we really had to look at our present clinic structure at Macquarie University Hospital and to some degree restructure it in order to provide capacity. So firstly, we needed to provide for potential extra testing slots in order to accommodate the needs of patients that are being reviewed. So we created extra capacity by essentially increasing the clinic hours by 1 slot for every cardiologist who was involved in the program, with echocardiography and stress testing available. And as specified, as I previously mentioned, each clinician's capacity who was involved in the program, essentially their 1 to 2 referral slots per day were quarantined to accommodate any referrals from the rapid access program. So if a patient, our commitment was really to accommodate patients within 1 to 2 days of the referral, and I'll go through in a little bit more detail of the manner in which patients are referred and prioritized. But essentially, where a GP might say that I want this patient seen within 1 to 2 days, they would be placed in one of those quarantine slots, and you would know the previous day as a clinician whether or not that slot was being made available. And consequently, you could rearrange your timetable, and you would know that on this particular day of the week, I may potentially have an extra patient, so you would arrange your timetable accordingly. So as specified, we aim to see patients within 1 business day if that is required. So if the GP specifies that this is something that is particularly concerning to them. The majority of investigation and testing we aim to perform at a single attendance. And we provide immediate feedback to the patient as well. One of the concerns, or one of the issues raised by patients when we consulted more broadly, was that they would go away from a specialist feeling quite anxious, not really understanding or appreciating the results of the testing that they may have had. So we make it a point to try and inform the patient to a reasonable level what the results be to them. And we also provide prompt feedback to the GP. So we have sort of really focused on this aspect of the program, which has been borne out to be quite important to GPs. So we provide formal correspondence within 1 to 2 days electronically, and where the consultation is deemed particularly urgent by the GP, and we ask them to highlight this at the time that they make the referral, we will usually make a phone call to the referring GP or to the practice to update them of the result of the consultation and the conclusions. So, the other aspect of this is because we operate as a hospital with multi-specialty and multi-subspecialty capabilities rather than a single standalone specialist, we're able to provide cross referrals where needed. And at the time of initial referral, if the referral is triaged as requiring a particular subspecialist, for example, if there's an arrhythmia disorder or a potential arrhythmia disorder, we might send that referral directly to one of our electrophysiologists. If it's an issue regarding heart failure, then we might send that referral directly to one of our heart failure specialists. And essentially, this is an attempt to decrease the number of patient attendances, which was highlighted as important in our initial investigation. So this is just a very broad, simple diagram to highlight this point that we aim to provide subspecialty services and evaluations and investigations expediently, with prompt feedback being a feature that we are very focused on. So in terms of engagement, GPs, we have found it really important to have the general practitioner community engaged at all phases of the program. And we've done this both by bringing on board GPs external to our institution to try and provide input on what is important to them, and also the general practitioners within our institution. We've engaged with them through various information nights and feedback sessions, and we also regularly provide GP education sessions to maintain that relationship and that sense of collegiality. Now, we leave it entire. We really place the onus on the general practitioner making the referral to stratify the urgency of review. We have found this to be a particularly useful aspect of the referral process, as we felt that the GPs often have a good sense of how important this is to both the patient and also to themselves. So I think we often underrate how anxiety-driven the patient might be when they have concerns, and the GPs having interacted with that patient is often at the best position to address that. And where patients are defined as being very urgent, we aim to see them within 1 working day. But generally speaking, we see patients within 1 day to 2 weeks, and we leave that stratification much to the GP. So in terms of the referral system, referrals are made by a GP to the clinic. The urgency of the referral is specified by the GP. Where it's considered urgent, then patients are scheduled for review within 1 to 2 working days. And where needed, an extra consultation slot will be opened up with one of the participating cardiologists the next working day. However, if a GP says, look, this is not a super urgent referral, then we have the luxury of being able to refer that patient to an appropriate subspecialist if that's required, or to the general cardiologist as required. So in conclusion, we've found in developing this program that partnership with a number of key stakeholders have been really important, particularly general practitioners, but also our local PHN. We've found it useful to identify the gaps in our present management model in our region. And I think that's important. I think locality to locality, those gaps will change, and the emphasis on each of those points will be different. We've emphasized rapid feedback to general practitioners, which I think has been one of the most important aspects to the success of this program so far. And we've also looked at strategies for time reduction where we can. I think in developing this, we've also found that there has been a constant need to increase the internal capacity to meet the expectations of our referrers. So with that, I'll wrap up. Thank you very much for your time, and I'll take any questions in the chat.
Thank you so much, Krishan. That was a really great presentation describing our quite unique service, I think, at Macquarie Uni. Chrissy, I can't start my video for some reason. It's stopped by, okay. Thank you. It seems Chrissy has control over the video. Okay, so I very quickly, because we are running short of time, I'm going to tell you a little bit about the evaluation of the HeartConnect program. Hopefully this sharing will work. Is that looking okay?
Go to presenter mode.
Yeah. Is that better? No?
Not yet.
Not yet. Okay. Now? No.
Not yet.
Okay. We're going to get Genevieve to share the slides, and I will talk to them. So I'll stop sharing now. Sorry about that. I'm not sure what's happening with my screens. Okay, perfect. Thanks, Jen. All right, so just some preliminary results around the evaluation for the HeartConnect service. So the service was co-designed, as you heard from Krishan, but the evaluation was also co-designed, and we actually implemented the evaluation from the very get-go. So it ran alongside the implementation. So it was a pragmatic, small-scale trial, one cardiology clinic and one primary health network. I'd like to acknowledge the people who have been helping with this. So Genevieve Damery, Gilbert Maggs, the researchers that have been involved along the way, Francisco Lopez, who's a GP practice manager, Simon Wilcock, who's an academic GP, Walter Komet, who's the CEO of MQ Health. We had 2 consumer representatives, and of course, Krishan and the cardiologists contributed significantly to the evaluation as well. So we undertook a mixed methods study, which involved surveys, interviews, some process measures. We were really interested in the timeliness of appointments, access to the tests and assessments, and referral and feedback processes, particularly the feedback back to the GPs. This was done at the level of the patient and healthcare provider, and today I'm going to tell you about that part. But we would like to also speak with the clinic staff, because as Krishan described before, it required quite a bit of change in terms of workflows to actually implement the referral pathway into the cardiology clinic. So we were guided by the Consolidated Framework for Implementation Research, but given this is a fairly small scale and short-term study, we were only able to look at certain domains of the CFIR. It would be great to do some cost analysis and to actually analyze coverage. But we looked at acceptability, adoption, appropriateness, some measures around fidelity, and the possibility of sustainability. The model hasn't really been running for long enough to know whether it's completely sustainable and scalable or not. So we were COVID affected. Since October 2020, 161 patients were referred to the service. 95 consented to be contacted for the evaluation study. We had a wide range of patients referred with the mean age of 54.4. So the sort of patient that you would expect to be referred to cardiology. The common reasons provided by GPs were further investigation of CVD symptoms, specialist opinion on management on both existing and new diagnoses, patients at high risk of cardiovascular disease, and having a recent cardiac event. So we were particularly interested in the process measures in terms of timeliness of referral. So between the referral and first appointment, the mean was 8.4 days, the median was 4 days. And the proportion seen within 48 hours of referral was about a quarter. Most were seen within 5 days, and almost everyone was seen within the 2 weeks of referral. Importantly for GPs, the letters back from the cardiologist to the GP after the patient was seen, that all of those, almost all of those, went on the actual day of appointment. So GPs and patients had very timely feedback about what was actually done in the specialist cardiology clinic with this patient. And over half of patients had all of their tests performed on the same day as their appointment, which is really convenient for patients because often they have to go to other sites to access tests and so on. So referrals were mostly from the Sydney North Health Network, and you can see the map there. It's northern Sydney, so it's a relatively advantaged area, but with some pockets of cultural and linguistic diversity and some disadvantage as well. As often happens, there were some early and enthusiastic GP practice adopters. So several practices were very keen on this program and referred quite a few of the patients. In terms of acceptability and appropriateness for patients, they particularly appreciated everything being in the one place, no need to travel to different locations for different tests, and ability to see or speak the cardiologist urgently. people were also able to access the service easily, even if they had disabilities, and you know, the special considerations were made for people who needed to be bulk billed. Level of satisfaction across the patients was on a scale of 1 to 10 was 9.1. And acceptability and appropriateness from GPs was high as well. They really appreciate the service. Patients are seen within a couple of days. The letters come back in a timely manner. They feel it's reliable and easy to get appointments. And we're analysing more data at the moment. We've just finished some of the data collection in June. So there's a lot more to come for this. So in terms of sustainability, the cardiologists tell me that this is now business as usual, but we really don't know whether that is the case and how it's going to go in the future, whether there's going to be enough capacity to maintain the service, and especially if the demand increases. So I think this space really needs to be watched in the long term to figure out how best to sustain and scale up such models. Okay, we'll move to questions now. I know there are a couple of questions in the Q&A, and we have precious little time. There's a question from Hannah Greenwood. With the ATCP-AC study, she's wondering what setting care was delivered in, clinic, GP, or somewhere else. And that's for Andrew. And
I think you responded to that, Andrew, but do you want to maybe talk to it?
Just briefly. So that was that's a good question. It was within the actual chest pain clinic itself. So the logic there is that the absolute risk assessment is really a primary prevention type thing, but because most of the patients coming through a chest pain clinic don't have a cardiac diagnosis at that time, they essentially form a bit of a primary prevention cohort, and we're putting that in place opportunistically because a lot of these people haven't had a risk assessment before, and they might not see a GP regularly. But I think the message from this would be equally applicable to general practice, and it's reassuring that a tool that's been recommended for widespread use in primary care, but maybe not thoroughly evaluated, this does suggest that it is a useful way of engaging patients and getting sustained benefit in risk factor management. And it's certainly anecdotally our experience in the clinic as well that it was really quite an engaging thing for the patients to see what their actual 5-year risk was. So putting all of their risk factors in context.
Fantastic. Thank you, Andrew. There was another question. I believe it's been answered online. We really are running short of time, so I'm sorry we can't really go through any more questions. However, if you do have a question, please feel free to contact us or the individual speakers if you would like to discuss anything or you want more information about the 2 models that were discussed, which were absolutely fantastic. Also, this webinar has been recorded and will be available on our YouTube channel. And the last thing for me to do is to really thank the speakers and the organisers, Chrissy and Genevieve. Speakers, Andrew, Neve and Krishan, thank you so much for agreeing to do this. And I think it's been a really fantastic sharing of information around these innovative clinics. So thank you very much.
Thanks for having us, Yvonne. Chrissy.
Thanks, Yvonne. Thanks, Chrissy.
Pleasure.